Hi everyone, I'm Carrie Dillon from class of 2019. In this video, we'll be discussing anemia. I'm going to go over mainly the different categories of anemia, and we'll kind of give you a couple examples of things, and in particular, the big, some of the buzzwords that are helpful for the test itself. So your anemic patient is usually going to be asymptomatic. Oftentimes, you'll find the anemia on a screening. If they do have symptoms, they're going to have some that are pretty non-specific, so fatigue or malaise. You might see something that deals with the fact that they're getting less oxygen carrying, so tachycardia, dizziness, or shortness of breath. If you have somebody with some of those symptoms or you suspect anemia, go ahead and get a complete blood count. From that blood count, a couple things that are going to be important is your MCV, and this is something that you're probably familiar with. So remember that when defining or when categorizing anemia, the first main category is based on microcytic versus macrocytic versus normocytic. Microcytic is your MCVs below 80, and that would be the acronym TICS. And then MCV above 100 is your macrocytic anemias, and everything in between is your normocytic. And this is just a slide that shows you the most common examples of all of those. For your microcytic anemias, let's first talk about the hemoglobin. So that is comprised of heme and a globin chain. So on the right side here, you'll see the heme, and that's a chain of carbons with an iron in the middle. There's one heme to each globin chain. So 4 of these globin chains with a heme to each one of them is going to make up your hemoglobin, and that's shown on this left side. And there are roughly 250 million of these hemoglobins in each red blood cell. So each of those heme is capable of carrying an oxygen, and therefore 4 oxygen molecules per hemoglobin. So you can imagine each red blood cell is able to carry a lot of oxygen. So I bring all this up because microcytic anemias are either due to defective globin chain or defective heme synthesis. And this kind of shows you which one's which. The thalassemias are going to be your globin chain. And remember, real quick here, alpha chain and beta chains, and you're probably familiar with these already, but remember, those are going to play a part in the type of thalassemia that you'll see. If you have microcytic anemia, checking your ferritin, your iron, your TIBC, which is your carrying capacity, is how you're going to be able to differentiate between these, and we'll talk about that in a moment here. The next couple slides are going to be covering some specifics about each of the types of the TICS, of that acronym that you saw previously, and we'll go over those briefly. There's going to be a lot more on these slides. You can pause if you need to and read all the way through it. But the big things I want to talk about for thalassemia is it is a decrease in either alpha or beta globin synthesis. They range in severity from minor, which is asymptomatic, to major, which can be moderate to severe anemia. You might see things like marrow expansion or extramedullary hematopoiesis. Best way to diagnose is with electrophoresis. You can see on a blood smear target cells, and those look like this here. That's a big buzzword for this. And you're going to see normal ferritin, iron, and TIBC. And you'll treat this with blood transfusions. For your iron deficiency anemia, this is because of a decrease in iron. This can be because of increased red blood cell turnover, or just malnutrition, malabsorption of not getting enough iron. If you have somebody with you suspect a GI bleed, especially in an older male, it is colon cancer until found out otherwise. Some things you might see is pica, which is the eating ice chips and different other types of food. Koilonychia, which is spoon nail. You're going to see on your labs decreased iron and ferritin and increased TIBC and RDW. RDW is a buzzword for this. That is because of the increased variation in the blood cell sizes. This is because the iron deficiency is leading to different sizes in the blood cells themselves. And treatment's going to be an underlying cause, but you can do iron supplementation as well with those. For anemia chronic disease, so this is when your body has inflammation and it's more or less hanging on to that iron or in a form of ferritin. You're going to see increased hepcidin, and that's going to lead to decreased iron absorption in the gut, and also the macrophages are going to hang on to that iron, so decreased release of that. You'll see some patients with chronic diseases, in particular autoimmune, like rheumatoid arthritis. You won't see it in a patient with osteoarthritis. You can't see it in chronic kidney disease because of decreased erythropoietin. But it will typically start as normocytic and can become microcytic, and you'll see decreased iron, TIBC, but increased ferritin, like we talked about. And with this, we're going to treat the underlying cause. You can consider giving them EPO. For sideroblasts, we'll just be really brief with this. There are reversible and unreversible causes. You can see those. You can read those here. With this one, you're going to see increased iron and ferritin, but a normal TIBC. And the buzzwords for this one is the basophilic stippling, which it looks like here. And then on bone marrow biopsy, if you do get one, you can see ring sideroblast. B6 supplement is a big something helpful to use for treatment for anybody with sideroblastic anemia, and you can treat the underlying disorder if it is reversible. Here's an overview of the lab values. We already covered some of these. You can take a look at the slide. Like we talked about the big buzzwords, target cells for thalassemia, an increased RDW you'll see with iron deficiency. The rest of them will have a normal RDW, and then the basophilic stippling for sideroblastic. For macrocytic anemias, remember this is at above 100 on your MCV. A lot of people will put macrocytic and megaloblastic as the same. But remember that there are non-megaloblastic macrocytic anemias, liver disease and alcoholism being the two most common. With megaloblastic anemia, this is because of an impaired DNA synthesis or an impaired DNA repair. One common finding you'll see with these is hypersegmented neutrophils, and that's going to be another buzzword when it comes to megaloblastic anemia. You can see folate deficiency, B12. Those are your two most common you're going to see with megaloblastic. There are other genetic causes, a couple that I listed there. I want to talk a little bit more about folate and vitamin B12 deficiencies. To distinguish between the two of these, based on the metabolic pathway, you can use a couple things on the labs to distinguish between them, including increased homocysteine, which you will find increased homocysteine in both folate and B12. However, you will only find increased methylmalonic acid in vitamin B12 deficiency. Is that because with the vitamin B12 deficiency, the pathway halts at that point? You only see neurological symptoms with vitamin B12 deficiency, paresthesias, for example. And then the timeline will tell you a lot as well. So when you think of folate, remember that you get that from things like spinach. Somebody who has been eating canned food and only canned food for a couple months is somebody that you would suspect for the folate deficiency. And then B12 is an animal product, so someone who's a vegan you can sometimes see this, but it has to be vegan for several years because you have a several year store of B12. For normocytic anemia, there's a couple different categories. Hemolytic versus non-hemolytic, and then from your hemolytic, part of your hemolytic characterizations is intravascular versus extravascular. We'll talk about that, and then intrinsic to the cell itself versus extrinsic, as in the pathology is outside of the cell, the red blood cells. These are characteristics you're going to find with your non-hemolytic anemias. Big one here is going to be reticulocyte cell count above 2%. They might show that on one of your test questions. For your hemolytic anemias, let's talk about intravascular hemolysis versus extravascular hemolysis and the things you're going to see. So intravascular, remember that's inside the vessels themselves. You'll find decreased haptoglobin, schistocytes, because those cells, like the red blood cells, are basically being cut apart. And then you will see hemoglobinuria and hemocistinuria, so you'll see that in your urine. Extravascular hemolysis is going to be taking place usually mainly in the spleen, and you'll see spherocytes on your red blood smear because those macrophages are kind of eating away at those red blood cells as they go through the spleen. Your non-hemolytic anemia examples, you can take a look at these here. Big one, anemia of chronic disease that we kind of talked about, and chronic kidney disease. You can also see an early iron deficiency as well. Here are your intrinsic hemolytic anemias. These are helpful to study. What I have put here is the pathology behind each example, along with the associations. These are the most common of the intrinsic hemolytic anemia examples. I'm not going to go over all these, but you feel free to pause the slide and take a look at these and study them further. For your extrinsic hemolytic anemia, this is usually due to autoimmune. Remember that there's warm and cold and the associations with those of IgG and IgM respectively. You'll typically see Coombs positive test. That can be direct or indirect. And this can be either a microangiopathic, so the smaller vessels, or a macroangiopathic, which is going to be your larger vessels. Oftentimes mechanical heart valves is the culprit for this. And finally, this is a slide showing the relationships of each of those three categories that we talked about and different examples within each one. Thank you very much for your time and have a good day.